I've been on planet Earth now for almost 65 years. During my lifetime, I've seen many instances where a person or maybe a group of people or a company or some other kind of organization had what seemed to be a great idea, and behind that idea were the best of intentions. But as that idea was implemented, things didn't go as planned. In fact, quite the opposite. The idea evolved into something quite different from what was intended. And such is the case with the topic of this video, pre-authorizations. We're going to discuss how pre-authorization system works today in present-day Medicare, what's gone wrong, the coming changes within Medicare, and most importantly, what you can do to avoid pre-authorizations. All right, I want to begin by answering this question, and that is this: what is pre-authorization? All right, first off, this is a kind of an official definition, and most of you have been through this, but I want to start here and talk about some of the issues revolving around a pre-authorization. First off, it says pre-authorization is when a provider, and this provider could be a primary care doctor, could be a surgeon, could be a durable medical equipment, could be a hospital, whatever. Different providers that they must obtain approval from the payer. Well, who's the payer? Well, the payer could be Medicare, the payer could be a Medicare Advantage plan or some other kind of an insurance company before delivering certain services. Why? To ensure that the service that they want to perform will be covered and paid for. That's a pre-authorization. Now, a couple items about this. Now, for billing and reimbursement purposes, Medicare uses what we call standardized codes to describe medical services, procedures, and supplies. And so these pre-authorizations revolve around codes. Certain codes are not going to require pre-authorization, others are certainly going to. So I thought it would help us to just really talk about the whole coding system. So I think you'll find this to be interesting as well as helpful. So first off, CPT codes. This is what they call level 1 codes. Now, what's interesting about CPT codes is this. These were actually created by the American Medical Association. And when we have a CPT code, it's actually 5-digit numeric code. So it's all going to be numbers, no letters that are involved. And so if we have an office visit done on an established patient and it's a moderate complexity, that would be the CST code 99214. So 5 digits. And again, this is one aspect of the coding system. Now there's a second one, and this is some letters here, HCPCS, and this is level 2. And this stands for Healthcare Common Procedure Coding System. This was current procedural terminology. That's for medical procedures. So this HCPC here is, these are additional codes, and this has to do with supplies and drugs, ambulance services, those kinds of things. And what's interesting about this one, this actually was designed by Medicare as well as Medicaid. And the numbering's different. Actually, we'll have a letter in front of it, and then we're going to have 4 numbers after that. So both of them 5 digits, this being all numbers, this being 1 letter, and the numbers to follow. Now, here's kind of a trick to be able to understand these different codes. I thought this was interesting. It is this: CPT codes, first one here, are mostly have to do with services. In other words, what was done to the patient. Okay, and this type of coding, level 2 codes, it was what was used during that service, which would be supplies and medical transport, drugs, those kinds of things. All right, so that's the system. And what I'm really trying to teach you is that as we talk about pre-authorizations with these codes, they say right now that in the Medicare system, there's about 7,000 different codes that can be used. And so the issue is, of those 7,000 codes, how many of these are going to require a pre-authorization? All right, so as we get into this whole idea of pre-authorization, the next question is, what's the purpose? In other words, why would someone have to jump through these hoops and go through this pre-authorization, prior approval before getting a service covered by the insurance company? So a couple of reasons. Number one is to control costs. This certainly would be the motive of the insurance company for sure, really even Medicare as well. So that's why they're going to attach some pre-authorizations to control the cost. And here is how they do that and what the whole purpose of. They want to be sure to reduce unnecessary utilization. Just so happens that sometimes services are ordered that really are not necessary. So the idea behind pre-authorization is to keep those reduced as much as possible. Number 3, then to shift to lower cost alternatives. So if we go to a pre-authorization process, it could could be that they may pay for that, but they would rather you do something prior to that. That would be what we call step therapy. And so why? Because those things maybe prior to this more expensive test could also be effective. So it gives the insurance company the opportunity to see if something else on a less expensive nature would also be effective. So that's the third reason. Fourth reason would be coordination of care. And so if we have a pre-authorization on an MRI and you just got one done by one physician and you see a specialist 2 weeks later, they may want to order the same thing. And so the insurance company certainly does not want to have to pay for two of those since they're done around the same period of time. So again, they want those to be coordinated so there's not, again, abuse of the system. And then fifthly, the reason would be for fraud. This would be to reduce the fraud, the waste, the abuse that goes on within the Medicare system. Sadly, billions of dollars are wasted every single year from fraud, waste, and abuse. And so again, this tool of a pre-authorization should be able to help that as well. So those are the 5 different reasons we have to jump through these hoops. All right, so that's what they are and why we have to have them. But now let's talk about really how common are pre-authorizations. What type of insurance you have will determine how frequent you'll have to undergo this pre-authorization process. So let's first off talk about the options now. And of course, I'm addressing those of you that are either approaching Medicare eligibility or already on Medicare. And so first insurance option here would be original Medicare A and B. A and B. So if we're in this system, that's our insurance. How frequent will pre-authorizations be? And the truth is, very, very rarely are you going to have to go through a pre-authorization with original Medicare A and B. Okay, it does happen a little bit. I'm going to give you a couple examples of that. There's going to be some changes about that in the future, but still very, very rare. And frankly, it's about 0.02% of the time. So it's very, very rare it happens, but it could happen. And then Medicare supplemental plans. So this is someone that enrolled in A and B, but to cover the financial gaps that Medicare did not cover, we get a supplemental plan. Most people today are getting a G plan or an N plan. Very good options. And those are going to fill in those gaps that Medicare did not cover 100%. And so a pre-authorization process when it comes to supplemental plans would be what? Never. The insurance company that wrote your supplemental plan, G plan or N plan, whatever plan you have, can never impose any kind of a pre-authorization on you. If Medicare pays, they're going to pay based upon the supplemental plan that you purchase. So we'll never have that happen. And then Medicare Advantage plans. Medicare Advantage plans, of course, began to really become popular around 2003. They've grown in popularity. About half of all people today that are on Medicare Advantage plan. And so how often? Regularly, okay? Often, people that are on Advantage plans are going to have this pre-authorization imposed upon them. As generally speaking, about 27% of all the services required on an Advantage plan are going to have to be pre-approved before we get that service covered and paid for by the plan. So again, that's going to be a regular occurrence on Advantage plans. All right, so that's going to bring us then to this next item, and that has to do the process that we have to follow when we have to go through a pre-authorization. And we're going to start by looking at that process as relates to those of you that are in original Medicare. And again, we don't have a lot of pre-authorization. There's 12 different items we looked at there. But how do we do that? What's going on behind the scenes? So first off, that provider that you're seeing, that could be a specialist, a surgeon, some type of doctor, durable medical equipment provider, but someone, the provider is going to identify a service that is going to require the pre-authorization. Again, doesn't happen often, but when they do, the process is this. They're going to submit that documentation necessary to a MAC, and this stands for a Medicare Administrative Contractor. Medicare Administrative Contractor. And so this is a third party. This is someone that Medicare hires to be involved in the claims, to be involved in the approval process. There's a lot of things that these Medicare contractors do. And so it's interesting, there's actually 12 of them around the country that are going to do A and B type of claims and works, and then they have 4 of these that actually take care of durable medical equipment, all right? And they're really very integral, very important part of how the Medicare system works. When there's appeals that go on, they look at local coverage determinations, national coverage determination, a very integral and very important part. But the whole point is that's where that paperwork is going to go. They're going to be the ones that are going to do what? Well, they're going to review the request, and then they're going to take action action. And so what are the options? Well, they could approve it, they could deny it, or they could just request more information. The provider just didn't give enough to get that particular service approved just yet. So that's the process. And then the turnaround time. How long does this take? Well, notice a standard, which they call a non-urgent type request. Medicare says those are typically done in less than or within 7 days. If it's urgent, some emergency situation, turnaround time is usually less than 48 hours. All right, so that's the process if we're in the original Medicare system. Now let's talk about the process when we're on a Medicare supplemental plan. We have that G or that N. What are we going to have to do? Absolutely nothing. I'm sure you're getting sick of me saying that, but I want to make sure you know, again, supplemental plans, no pre-authorization, so there's no process whatsoever. It is your doctor and Medicare that make the decisions. Okay, that brings us then to our Advantage plans. Those of you that choose Advantage plans, what's the process there? So again, what's going to happen is that provider, doctor, surgeon, DME provider identifies a service that requires a pre-authorization subject to the rules that the Medicare Advantage plan has. Okay, and so now we're way beyond that list of a dozen, and so it's a list of all the different things we went through a few minutes ago. And so they identified that service, whether it's an MRI or a CAT scan or a knee replacement, a hip replacement, chemotherapy, all those things. What's the process we go through? Well, that provider, again, is going to submit documentation to now the insurance company. They're the ones that are going to make that decision. Medicare allows them to impose additional pre-authorizations, and so that paperwork is going to have to go to them for approval. All right. Now, the insurance company then is going to review the request. And again, they're going to make a decision. And again, same thing, they're going to approve it, they're going to deny it, or they may request more information. All right, now one of the difficulties that providers have is because each of these insurance companies have their own process, sometimes their own different paperwork. One company may not require pre-authorization of a certain service and someone else does. So it can be very burdensome to the doctors and surgeons because they have to know how each of these plans are going to function and then when they require pre-authorization and what paperwork is going to be necessary. All right, but that's that process. And then the time frame is this as it stands today. And we're going to see there's going to be some changes in this in the future. But as it sits today in 2025, if it's a non-urgent request, Medicare says that insurance plan must get back with that provider within 14 business days. If it's urgent, they have 72 hours. All right, now some of these truly are real time. In other words, they're very simple. It can be a real time type of a decision, but they do have this time frame that they have to live within to make sure they're giving those providers the decision. All right, that brings us to the next item, and that is going to be the problems that are associated with, notice, MA, Medicare Advantage pre-authorizations, because there's lots of them, so they happen on a regular basis. So what are the problems with these pre-authorization within the Medicare Advantage system? So the first problem is volume. There's a lot of these that go on. Notice this, look at this stat. Back in 2019, we had 36 million requests that providers sent into the Medicare Advantage system, 36 million of them. 4 years later, 2023, we don't have the 2024 numbers yet, but 50 million in 2023. So tremendous amount of volume. In fact, I read where most doctors say they have to have at least one staff member or more. That's their full-time job, just taking care of the pre-authorization process. Okay, so lots of volume. Now, what's interesting about all this volume, notice here, back in 2019, 5.7% of all these claims of these 36 million were denied, but that increased in 2023. Again, we don't have 2024 numbers yet, but 7.4%. So what's that mean? When you do the math on that, we're talking about almost 4 million. I mean, Leah, 3.5 million people had their request denied, or they may have got the service, but they had to go back in and appeal to get that covered service. So the whole point is that's millions of people affected by this pre-authorization request. In fact, they say right now that every enrollee is going to have to go through this at least once to 3 times on an annual basis, kind of the average, 1 to 3, to go through this process. Now, when it comes to denials, the story is not over yet because everyone who gets a denial has a right to do an appeal. But look what happens. Notice this, the appeal rate, of course, right around 11% in both of those years, so a little bit less than 12% of all those people that were denied actually took the time to see if there could be a reconsideration and an approval of that. So what's that saying? Almost 90% of all people just give up. The doctor felt like they need the service, but they're saying not worth the hassle, and they don't even try to appeal. but they should, okay? Here's why, because look what happens. Look at the approval rate. Over 80% of all people, they just simply would appeal, they would win that. So what's that tell you? Why on earth did those 80% of people get denied in the first place? Well, there may be some good reason, but there may not be. There could be some really unjustifiable reasons. And again, that's one of the pain points of Advantage Plan pre-authorizations. Why didn't they approve in the first place? And so that happens. In fact, they say right now that about 13% of all claims, had they gone in to original Medicare, they would not have had a pre-authorization process in the beginning. I mean, original Medicare says that should be covered. And so again, that should have been a no-brainer. But again, these companies still do denial of services. All right, now that brings us really to the largest problem that we have with Medicare Advantage pre-authorization, and that has to do with post-acute care. This is a care that's we need after hospitalization. This could include some kind of rehab at home, and it could also include rehab in a skilled nursing facility, but this post-acute care that we need to be able to return to normal life, to be able to heal, to be able to function again physically. And so post-acute care is very, very expensive, and it can cost MA companies a tremendous amount of money. So let's go through, I'm going to share with you 6 different features, and we're going to make a comparison between original Medicare and Medicare Advantage as it relates to pre-auths with post-acute care. So first off, when we think about this post-acute care, prior authorization required for a skilled nursing facility. And as we said earlier, if I'm in original Medicare, I have to have a 3-day hospital stay. Doctor says it's medically necessary for me to go there. So again, original Medicare does not require a pre-authorization at all. But notice, 99% of all the plans that people are enrolled in today, before you go to that skilled nursing facility, it is going to have to be pre-approved or will not be covered. All right? Number 2, feature. Prior authorization required for, again, home health care. Again, doctor says you need it, original Medicare says covered, no pre-auth. But look, 97% of the plans that are on the market today will require pre-authorization for home health care. Third feature, the length of stay. Length of stay, how long are you going to get to be in the skilled nursing facility? Who determines that? Well, notice if you stay in original Medicare, it is your doctor and the CMS rules, of course, that dictate everything. But over here, now we have the insurance companies, their rules and their guidelines, which oftentimes are above and beyond the original Medicare guidelines. Okay, number 4, the appeal or denial risk. In other words, the risk of getting that denied or the risk of having to get a denial and go through that process of appealing. Notice, very, very low in original Medicare, quite high when it comes to Advantage plans. All right, flexibility and provider choice. In other words, what kind of facilities can you go to for the rehab, whether it's outpatient or a skilled nursing facility, all those kind of things. Very, very high provider choices. Why? Because as long as the provider takes original Medicare, you can get your service from them. So it's not limited whatsoever. We call that an open access system. Anyone that takes Medicare, go where you want to go. Not so when it comes to an Advantage plan. It's going to be restricted. Why? Because the great majority of them have some kind of a network of providers, limitations, HMOs or PPO plans. And again, all the providers are going to take those plans. And so again, you're going to have some restrictions there. And then lastly, notice this one. This says AI, artificial intelligence, of course, tools that will be used to guide the coverage. Okay? In other words, in that determination to should you go there and how long can you stay there, will AI be involved? Will the algorithm be involved? And you're going to notice when it comes to original Medicare, absolutely not. It's the clinician, it's the docs. They're going to make that decision, but not so necessarily with the Medicare Advantage. There will have some AI involvement. I'm not saying they make always the final determination, but they definitely, AI has a role in it. Okay, there's a system called NH Predict, and that's a very specific algorithm designed to tell the providers this is how long they should be in skilled nursing with this particular condition. 16 days, 27 days, 4 days. And again, there's some pressure upon those clinicians to really abide by what the algorithm is saying. Okay, and so the point is we see the variance here, the difference between these two different systems. And then just one more stat I wanted to share with you. I found this to be interesting. There was one of the MA carriers, their post-acute care, again, home rehab, skilled nursing facility, those kind of things, their denial rate, look at this, increased from 2019, it was just 1.4%, didn't happen very often. Notice in 2022, the latest stat we have on this was 12.6%. Okay, just one carrier. And remember what I said overall, when it comes to post-acute care, there was a study put out by, I think the Senate Finance Committee. I think it said there was 25% of all MA pre-authorizations were denied as it related to post-acute care. Now, that was not all skilled nursing. Some of that had to do with home health care and home rehab as well. But again, 1 out of 4 denial. And so again, there's quite a process that's involved whenever we're going to get post-acute care. And the reason for that is because it's very expensive. I think right now they say the average daily rate that Medicare as well as Advantage plans will pay the skilled nursing is somewhere between $500 and $560 a day. You multiply that times 7, someone's in for 7 days. What is that? That's over $3,500 in a week that it's costing that Advantage plan. All right, and so the average stay right now, I think, is right about 37 days. And so you can see why it is that these insurance companies want people to get out of there, either go to a cheaper care at home or to just flat out not cover them anymore for their post-acute expenses. Now that brings us to the changes that are going to happen within these two systems. I'm going to share that with you. Before I do, many of you right now are contemplating going on Medicare, or maybe you're not contemplating, you know you're going to have to do it. And the question is, do you feel like that you have the knowledge that you need to make a great decision, the right decision for you, and not make any kind of mistakes? Well, if you're unsure about that, I would encourage you, go to the link here just right below, and you just answer a handful of questions, and you'll find out, do you really know what you need to know to make great Medicare decisions? And our whole goal as a company is to help people go on Medicare mistake-free. So let's see if you can do that. So go take the quiz and continue to learn. Okay, let's keep going. Now, I want to talk now about the changes that are coming to pre-authorizations. Now, again, has been our pattern. We'll look at original Medicare, Medicare supplemental plans, and Medicare Advantage plans. So what are the changes now coming to pre-auths for original Medicare? Well, this all happened with the passing of this last legislation that was called the One Big Beautiful Bill Act. And so part of that legislation, implementation of all this, was a program called WISER. And it's an acronym that stands for Wasteful and Inappropriate Service Reduction Model. As you know, the Department of DOGE have been trying to identify different things within all government agencies where there is some waste, some abuse, some fraud, and all of that. And they want to reduce that. And so this has to do with original Medicare, a way they believe they can identify some services that are really overused. And so this particular plan, the WISER plan, is going to start January 1 of 2026 here, in the next year. I'm shooting this video, by the way, today is July 31st on a Thursday, but here in just a few months, this will be implemented, this WISER system. And notice it's going to go through December 2031, and so it's going to last for 6 years. It's just a test pilot plan. I'll give you the details of it. So what you're going to notice is with this plan that's going to last 6 years, it's only for 6 states. And you're going to notice they kind of spread these out throughout the country. But Arizona will be part of the test, New Jersey, Ohio, Oklahoma, Texas, and the state of Washington. All right, they'll all participate. And then you're going to notice that this pilot is for 17 selected services. 17 selected services. So again, we're already seeing that original Medicare had about a dozen. And now they're going to add 17. How many are there out there? 7,000 potential services. So again, this is going to affect very, very few people, but it is going to affect some. And let's look at the details of that. These 17 services are actually broken down into 7 different subgroups. And so I'm going to go through them with you real quickly, just so you're aware of them. So the first one has to do with nerve and brain stimulators. They are now going to be part of the pre-authorization process. Quickly, what does this mean? These are electrical nerve stimulators, small devices placed under the skin to send mild electrical signals to nerves. These oftentimes will relieve chronic pain. Sacral nerve stimulation. This helps people with bladder or bowel control problems. Again, stimulating the nerves. There's another one called phrenic nerve stimulator. This helps people who can't breathe well on their own to stimulate, the nerves within the diaphragm. Deep brain stimulation. These are tiny wires that are placed in parts of the brain to send electrical signals. It's used for those that have Parkinson's disease or essential tremor and movement disorders. And they do this whenever medications no longer help. They try the stimulation. There's one more. It's the vagus nerve stimulation. So this device sends pulses to the vagus nerve that's in the neck, and it can reduce seizures, epilepsy, or improve depression when other treatments fail. So that's one aspect of these 17, those particular 5. The second one would be pain and nerve procedures. This includes lesions of nerve tracts, This procedure, interestingly enough, it intentionally damages small areas of nerves that send pain signals to reduce chronic pain when people have cancer or severe chronic back pain. There's another one called epidural steroid injections. These are injections that are placed near the spinal cord to reduce inflammation and pain in people with back problems or sciatica. Also in this list, percutaneous vertebral augmentation. That's quite a word. A type of spine surgery where bone cement is injected into bones, broken spinal bones, usually from osteoporosis to relieve pain and stabilize the bone. So that's the second group. Okay, and that was 3 of those. And all I'm trying to teach you is, of these 17 services, remember now, we're going to have to go through the pre-authorization process. So as long as it's proven to be medically necessary, the documentation is there, this is something Medicare will cover. The third group would be spinal and orthopedic type of things. This would be cervical spine fusion. This is a surgery to join together 2 or more neck bones, the vertebrae, to stabilize the spine, often when discs are worn out or there's been some kind of nerve damage that has occurred. Another part of this would be arthroscopic knee type issues. This is when a camera and a small tool is inserted into the knee to flush out debris or damaged tissue. This usually is a result of osteoarthritis. And so many believe it's not very ineffective and sometimes overused. So again, they've added that to the pre-authorization list. Next item would be sleep and breathing issues. This is called hypoglossal nerve stimulation. So again, this is going to be a device that's implanted in the chest, and it stimulates a tongue nerve during sleep to keep the airway open in people that have sleep apnea and cannot tolerate CPAP machines. All right, number 5 would be urinary and sexual health. This is incontinence issues or impotence issues. Again, these are going to have to be pre-authorized. Spinal decompression. This would be when someone, it's a minimally invasive procedure that removes excess tissue that presses on the spinal nerves. And this helps with people that have leg pain or difficulty walking when they have spinal stenosis. Again, could be covered, but again, pre-authorization. And then the last group would be wounds and skin substitutes. If you paid attention to the news recently, there was actually a fraud case of over $1 billion for things like this. In fact, I think this is really kind of what triggered this whole issue of Medicare through DOJ defining some of these issues that are just overly abused and maybe not real effective. And so here, 3 items here. One is called bioengineered skin substitutes. And this is a special wound covering that's made from human or animal cells used to help hard-to-heal foot or leg ulcers. This happens oftentimes in diabetics. Another one would be wound application, and this would be very similar to the bioengineered skin substitutes. These are advanced dressings that's made from donated skin or synthetic materials to stimulate healing whenever there are chronic wounds. And lastly, skin and tissue substitutes. This is a broader category that includes engineered grafts and patches that are used to treat non-healing wounds. They just won't heal up. This would be skin loss from burns or surgical wounds. And so these are the items now that are going to be added. And again, there's 17 of them now. So we had a dozen, now we have 17 more. And as I said, of the 7,000 that Medicare will cover. All right, now that brings us to the last point with the WISER program. Notice this, the provider, one providing these services, can request, now watch this, a pre-service review. What's that? A pre-authorization. Or what can happen, they can request a prepayment review. This means they're not going to ask for an advance approval. They're just going to go ahead and do the service, and then they'll submit the documentation and to see if it will be paid. And of course, this is a provider that's pretty sure it's going to be paid, and so they're not worried about that. But the whole point is, under this program, it doesn't necessarily have to be a pre-authorization, but then that provider would run the risk, if they don't submit the proper documentation, for that payment either be delayed or denied. Wouldn't affect you as the patient for sure, but I just want to make sure you know that these are the 2 ways in which reviews can be handled within this particular program. So what do we have? 17 additional services. It's going to affect 6 states, beneficiaries within those states, and it's going to last 6 years. So we'll see how it goes. All right, that brings us then to, again, supplemental plans and the changes that are occurring for pre-authorizations with those plans. And again, no changes whatsoever. Why? Because, again, your doctor says you need it, Medicare says we're going to cover it. Supplemental plans have no say-so whatsoever. They always follow Medicare. All right, so that brings us then to the changes that are going to occur for pre-authorization process within Medicare Advantage plans. Okay, so first off, the plans are going to have to publicly report their prior authorization metrics. And again, we saw earlier, a problem has been hidden. There was no transparency by the companies, and so now they're going to have to report on the metrics. They're going to have to start tracking and reporting. Notice the volume of these. We just saw that in the last report of year 23, there were 50 million of those. So they're going to report that. What's the approval rate? Remember, we looked at that. Right now, it's running about 92, 93% for average services. So they're going to have to report the approval rate, and then also the denial rates and the appeal rates, all that, and the timeliness. How long does it take them to make those decisions? Number two, reducing the scope of PA requirements. So what I mean by that is we know there are hundreds and hundreds of services that have to have a prior authorization. So what's going on now is the companies have to commit to reducing those. One insurance company recently said they were going to try to reduce theirs by 33%. So if they have 500 prior authorizations, they're going to eliminate 33% of those. They're going to eliminate 150 of those. So they're still going to exist, but they're supposed to be less of them. All right, and so that was their commitment. Number three, so what's happening beginning here in just a couple of months, January 1, all the Advantage plans are going to have to follow what's called the FHIR, which is the Fast Healthcare Interoperability Resources. Okay, basically look at this as their common language that they're going to now use within their claims, and it's going to be based upon electronic prior authorization submissions. And so they're going to try to expedite it by making this electronic, so there's no more phone calls and faxing. And again, this isn't going to happen overnight, but they're going to start to initiate these electronic PA submissions in real time. And so now they have this common language they're going to share. So that I think will be helpful. And then they have to be also held accountable to this new decision timelines. And so right now, a Medicare Advantage plan on non-urgent request, standard request, they have 14 days. Beginning January 1, 2026, that's going to be reduced to 7 days, cutting that in half. For urgent requests, those that are not standard, it's going to be 72 hours, and that's the existing rule now. They're just going to carry that over. Many within the medical field said, hey, we want that decision within 24 hours. And the Advantage plan, pushed back on that, and so they actually got their way instead of the providers getting their way. All right, so that's that. Then number four, beginning in January 2027, they have the goal now to deliver real-time electronic responses. And notice what they're saying is their goal is to make sure that 80% of prior authorization requests going in are done in real time. Which means what? 20% are still not going to be, and then again, that's a high goal, and again, they may reach that. We're not really sure. And by the way, I do want to mention they actually made this commitment before. I think it was back in 2018, 2019, and really nothing came of it. Kind of fizzled away. And I think they're concerned that the government is going to crack down on them. So now they have voluntarily saying we're going to participate in this particular program. All right. So notice this. Ensuring care continuity when switching plans. This is a big deal because there are 2 times a year that people can switch Advantage plans. We can do that October 15th through December 7th for an effective date of January 1, or we can do it the first 3 months of every year, January 1 to March 31. So if we switch Advantage plan, let's say we move from ABC Advantage plan to XYZ Advantage plan, and we had a prior authorization approval, in the old days, it didn't go to the new company. It didn't pass on. You had to change companies. You have to go back through that prior authorization process. So now what they're going to make them do is they're going to say that continuity when they switch plans, so that prior authorization from ABC Insurance Company is now good for 90 days. So it'll carry over to the next Advantage plan. So that was one of the goals as well. All right, now also they're going to require clinician-led reviews for denials. Now AI is still going to be a huge component of all this, but when there is a denial, they're supposed to say, and they're saying we'll make sure there's a clinician that also reviewed that. Now the question is, who's the clinician work for? So there still could be some issues going on there, but the point is they're going to make sure that AI is not making all the decisions. All right, so those are the changes that are going to start then in January here this next year.